Good morning. I'd like to thank the moderators and sages for the invitation to present. I have no disclosures for this presentation. This is your patient. He is a middle-aged male with a history of an open abdomen and previous poor wound healing. He's undergoing a complex abdominal wall reconstruction. You get him through his operation and his first post-operative visit without any issues, and then unfortunately, he returns to the emergency department with this CT scan. What do you do next? For the next 15 minutes or so, I'm going to briefly define wound events and wound categories. We're going to talk about preoperative optimization and intraoperative considerations that may help reduce the risk of postoperative wound events. And finally, we'll talk about some clinical scenarios and management of wound events. I do have two warnings for this talk. The first one is that it's supposed to be interactive, so we are going to ask for audience polling. And two, as you may see from the answers from the audience polling, there's not necessarily one right or best way to manage a postoperative wound event, and most of what I'm going to talk about is how I manage wound events at my institution. So SSO, SSI, SSE, SSOPI, what do these acronyms mean? What wound events fall into each category? In 2018, we published a paper entitled A Call for Standardization of Wound Events Reporting Following Ventral Hernia Repair. We looked at the 50 top cited ventral hernia repair articles from 1995 through 2015. And interestingly, we found that the incidence of postoperative wound events varied significantly from 0.7% to 63.3%. We also found that 18% of papers use a standardized definition of wound events, 28% use study-specific definitions, and 54% of papers listed wound event types without any definition. And therefore, we hypothesize that this difference in wound event definitions likely contributed to the significant variation in postoperative wound event incidence. Therefore, we encourage hernia surgeons to begin using a common language in three standardized wound categories, including SSI, SSO, and SSOPI. I think it's also important to talk about preoperative optimization as it contributes to a decreased incidence of postoperative wound events. So in no particular order at my institution, patients do not undergo a preoperative bowel prep. For our transplant patients, we try to transition them off of their mTOR inhibitors, and then we work with our transplant medicine colleagues to help reduce the dose of their additional immunosuppressive medications, if at all possible. We ask our patients to lose weight with a goal BMI of less than or equal to 35. They do not undergo a home preoperative chlorhexidine scrub. Patients must have a downtrending hemoglobin A1C level as close to 6.5% as possible. And then we make our patients quit smoking for 6 weeks preoperatively with a negative urine nicotine test. In addition to preoperative optimization, there's also some intraoperative considerations, including your mesh type. So we choose or prefer a macroporous mesh, which helps with tissue ingrowth and resistance to infection. Mesh location in a well-vascularized plane, drain placement, wound closure, including excision of excess skin and subcutaneous tissues, an incisional wound vac system, and finally, the avoidance of flap creation if at all possible. Despite these intentions, sometimes bad things do happen, and that's what I'm gonna talk about for the remainder of my time up here. So this is now audience polling. So I think it's on polleve.com. I think if you go to the session, you can click on the polling and it will take you there. Everyone ready? So this patient is post-op day 2 from their ventral hernia repair. On morning rounds, you note new erythema at the inferior aspect of the wound. What do you do next? A, open the wound. B, begin IV antibiotics. C, begin oral antibiotics. Or D, open the wound and begin antibiotics. Okay, can we close? So the answer is D, open the wound and begin antibiotics. This patient has wound cellulitis, which by definition is superficial inflammation without a drainable fluid collection. You always want to probe the wound to see if it opens easily and then pack that area. Typically, these patients have an elevated white blood cell count. You want to start IV antibiotics and ultimately transition them to oral antibiotics at discharge, or if you diagnose the cellulitis in their postoperative visit, it's reasonable to begin oral antibiotics. And you always want to consider MRSA coverage for your high-risk patients. This includes patients with a known history of a previous MRSA infection and your immunosuppressed patients. Next scenario, this patient returns to the emergency department with a low-grade fever, elevated white blood cell count, and spontaneous drainage from their midline incision. What do you do next? A, percutaneous drainage, B, IND at the bedside, C, IND in the operating room, D, begin IV antibiotics, do not open the wound since it's already draining. This is a poll question. Those are the wrong answers, sadly. That's wrong too. Okay. So the answer is B, IND at the bedside. This patient has a superficial abscess, which is above the anterior fascia. Their mesh is in the retrorectus space. So a deep wound infection, by definition, is above the space of the mesh. If your fascia is intact, it's reasonable to open this wound at the bedside, although, of course, you also want to evaluate the integrity of your fascial closure and make sure that you don't have any exposed mesh. Typically, we perform wet to dry dressings until the wound bed is clean, and then we transition to a wound vac, and we begin IV antibiotics with tailoring of those antibiotics based on the cultures at the time of the IND. This patient returns to the emergency department and clinic multiple times within the first 2 months following surgery with intermittent diffuse abdominal wall erythema. What is your diagnosis? A, cellulitis, B, incisional ischemia, C, infected stroma, or D, mesh infection. Okay. The answer is D, a mesh infection. So this patient had an early mesh infection, which again, by definition is an organ space infection because that's where your mesh is located. These mesh infections are typically difficult to diagnose and patients present with ominous findings. You need to have a higher suspicion in contaminated cases as well as recurrent ventral hernias. This patient had both of those risk factors. Your initial treatment is with 4 weeks of antibiotics, again with consideration for MRSA coverage for your higher risk patients. And then it's important that you counsel your patients that they're a higher risk for progression to a chronic mesh infection or hernia recurrence. Scenario 4, this patient is in clinic for their first postoperative visit. How would you treat this finding? A, remove the surgical dressing, B, topical steroid ointment, C, oral Benadryl, H2 blocker, and steroids, D, a combination of A and B, or C, a combination of A and C. The answer is D, a combination of A and B. This patient has contact dermatitis. You can see this at any point during their follow-up, either while they're an inpatient or at the time of their clinic visits. The erythema typically follows the distribution of the glue or tape used on the incision. Patients are typically symptomatic, as you can see in this picture. In addition to the petechiae, they typically have itching in the area and some warmth to touch. You want to remove any remaining dressing and get rid of that nidus for contact dermatitis, and then begin a topical steroid ointment. Scenario 5, this patient underwent ventral hernia repair with undermining of the subcutaneous tissues. They are asymptomatic without a white blood cell count. What would you do with this finding? A, immediate return to the OR, B, bedside opening of the wound, C, begin IV antibiotics, or D, await demarcation before intervening. The answer is D, await demarcation before intervening. There's 2 clues here. The first is that this patient underwent undermining of their subcutaneous tissues, so the vascular supply was likely interrupted, and the patient did not have an elevated white blood cell count. Wound ischemia is typically not an infectious process. which means you have time to wait until the area demarcates, and then you want to return to the OR for complete excision and debridement of the area of ischemia. You're gonna ultimately transition this patient to a wound vac to help with wound healing. Scenario 6, this is a kidney pancreas transplant who had an episode of acute bleeding following ventral hernia repair. They now have an elevated white blood cell count with this finding on CT. What do you do next? So the CT is gone, but the patient has a subcutaneous fluid collection, which is above their mesh. The answer is E, a combination of B and C. So typically we don't chase after seromas and hematomas in the immediate postoperative period, but this patient had an elevated white blood cell count. It's important to consider whether you're going to aspirate the fluid collection only or place a drain. Because the hematoma was above the mesh and in a different plane, we felt comfortable placing a drain for this patient. You also begin empiric IV antibiotics and tailor those based on your culture results from the IR procedure. Scenario 7, this is a patient who has undergone multiple previous ventral hernia repairs who presents to your office with a long-standing fluid collection and ventral hernia recurrence. What would you do next? A, IND in the clinic, B, IR aspiration or drainage, C, IR aspiration or drainage and sclerosis, or D, either B or C. The answer is D, either B or C. So this is sort of another exception to the rule. This patient has a chronic seroma. The seroma needs to be managed before you repair their recurrent hernia. It's reasonable to start with IR aspiration, but if the fluid cavity returns, you should proceed with IR drain placement and sclerosing of the cavity. Just remember that the sclerosing is only gonna collapse the cavity. It's not gonna get rid of the cavity. And so the cyst cavity requires definitive excision at the time of your recurrent hernia repair. Scenario 8, what is the diagnosis for this wound event and what can occur next? Wound dehiscence to fascial dehiscence, wound dehiscence to wound ischemia, wound dehiscence to exposed mesh, or wound dehiscence to evisceration. The answer is C, wound dehiscence to exposed mesh. This is ultimately what the patient looked like, and that top area is some exposed mesh. You want to open the area widely and perform wet to dry dressings with an ultimate transition to a wound vac system once the wound bed is clean. You need to explain to the patient two things. One, this is likely going to be a slow and long process. And two, it's possible that with wound dehiscence, you may ultimately develop exposure of the mesh. If you have mesh exposure, you want to excise the portion of the mesh that is not incorporated or surrounded by granulation tissue. Unfortunately, the wound often contracts rather than fully healing, so you may need to perform a split thickness skin graft to cover any remaining exposed mesh. Final scenario, this patient had ventral hernia repair 5 years ago and presents to clinic with a chronic draining wound. What is the most likely diagnosis? A, mesh allergy, B, chronic mesh infection, C, suture granuloma, or D, chronic seroma. The answer is B, chronic mesh infection. So chronic mesh infection differs a little bit from an early mesh infection in that the mesh itself cannot be salvaged. It requires complete excision of the mesh. And the patient must understand that when you excise the mesh, you're ultimately leaving them with a recurrence of their hernia, which will be repaired in a staged fashion once the infection is gone. In conclusion, wound events are a common occurrence following ventral hernia repair. Preoperative patient optimization and intraoperative considerations may help reduce the risk of postoperative wound events. There is more than one right way to treat most postoperative events, as we saw with some of our polling answers. The emphasis is on early and aggressive management of these events to prevent progression and ultimately reduce their morbidity and hernia recurrence risk.